shi yasa kamar kwanaki an kawo wani yaro a nan yana fama da rashin lafiya na malaria, so yaron ya fara suma, to mu kuma nan ba magani. Mun yi kokari ko mu tura shi gari, bayan mun rubuta takarda mun tura shi general hospital, so yaron daga karshe dai kafin su ce za su tafi gari su je a musu komai da komai sai yaron ya rasu.
Tana naguda ba malaman asibiti, ta haihu jini ya kwalala, ba hanya ba a yadda da mu yi mu tafi asibiti, ba malaman asibiti, muna kokarin mu je ta rasu.
Na ɗaya dai ba mu da ɗakuna inda ma'aikata in an ajiye su za su kwana. Akwai abin da ya faru cikin kwanaki, amma ba a nan anguwan ba. Mace da ta zo aihuwa dai ta rasa ranta da shike a gida ta aihu. Ta fara ne da zuban jini. Kafin a ce za a tattara zuwa asibiti, jinin jikinta ya riga ya zuba ya kare.
In northeast Nigeria, there is a health emergency of epic proportions. Thousands of women die at childbirth, and under 5 mortality rates in the region are 54% higher than what obtains in the southern parts of the country. The vast majority of the women and children who desperately need healthcare services rely on primary healthcare centers for these services. However, poor infrastructure, lack of skilled manpower, and an acute shortage of drugs have made it impossible for them to access quality care, resulting in the worst infant and maternal mortality statistics in the entire country.
There are a lot of maternal deaths as a result of lack of infrastructures, lack of trained manpower, and above all, lack of equipments to handle most difficult cases in our facilities.
Da an aje mu domin saboda mu taimake su ne, amma da an zo an kawo an zo aje maganin babu da me zama taimake su. Domin ce idan za a zo maka a wannan gurin haka dai a zo maka da bukata sai a zo a tayar ba ka da weighing scale. Akwai zafi sosai a rayuwar mutum.
These poor indices have been made even worse by the Boko Haram insurgency, which engulfs the entire northeastern region of the country, claiming over 20,000 lives and displacing more than 2 million people since 2009.
You know that in Borno alone there's a displacement of over 1.5 million persons, some of them in IDP, some in host communities. So there's a great strain on services provided by primary health care, both in the community level and the health facilities. The state has lost about a third of its primary health care facilities. We have lost quite a lot of human resource for health. In fact, some lost their lives, some left the state completely. If you look at number of malnutrition cases increasing, delivery by skilled birth attendants is reducing because of of course, you don't have space, you don't have human resources, immunization data. A lot of primary healthcare services indices are actually going down.
The General Hospital, Mulai, which also doubles as the biggest leprosarium in the entire Northeast, is a secondary health facility that is situated just outside Maiduguri. The hospital lies just a couple of kilometers from the infamous Sambisa forest, the operational base of the insurgent group Boko Haram. At the height of the crisis, the group attacked the facility on multiple occasions, killing health workers and destroying sections of the property.
When I came to this hospital, we have about 200 and I think close to 30 staffs. Now we have 4 doctors plus me, 5 in this hospital. Boko Haram struck inside the hospital more than I think 2 times. Because of the dilapidated structure and the lack of manpower, everyone is stretched to a limit.
Although life is gradually returning to normal, a combination of decades of neglect and mortar attacks now paint a picture of a hospital in desperate need of assistance. Bulabulin Primary Healthcare Center is a small health facility located in Garanam, Borno State. The health center plays a very critical role in ensuring that thousands of women and children in the surrounding communities have access to healthcare. This health center, for a time, was held hostage by Boko Haram, who vandalized the property and made it impossible for people to access the care that they desperately needed.
There was a lot of problems at that time because we were only 7 working here with only 1 cleaner. At that time, there was no potable drinking water, no borehole. We have to come along with our drinking water from our homes, and even the tools were not adequate. Yes, and there are a lot of outbreaks of so many conditions. Children dying of vaccine-preventable diseases. So we had a lot of problems at that time.
Primary healthcare facilities are designed to play a very important role in providing basic healthcare services for Nigerians. Many of these facilities are located in semi-urban and rural areas where the vast majority of poor Nigerians live.
Primary health care serves more Nigerians than any other level of care. It's the first contact of most Nigerians with the healthcare system. More than 70% of our population live around where primary health care can service them.
In some parts of the Northeast, several communities may rely on just one health facility for their medical needs. However, most times, due to inadequate manpower and scant resources, the facilities are unable to deliver these services, which often results in higher mortality rates.
The primary health care has suffered a lot of setback. The challenges, ranges from inadequate human resource, inadequate skilled births attendants at these facilities, very dilapidated infrastructures. The buildings are just not there. The essential commodities are not there. The drugs are not there. And because of that, services are not rendered much.
Among all the states in northeast Nigeria, Bauchi State has probably the worst health statistics of all. The state has the highest number of malnourished children and one of the worst infant and maternal mortality indices in the country. At the root of this problem is an acute shortage of skilled health workers in the 1,000 primary and secondary health facilities spread across the state.
Gaskiya matsalolin da muke samu a nan yawanci gaskiya daga fari dai ni ɗaya ce a nan mace. Kuma a nan a al'adarmu a nan maza ba sa duba mata. In sun zo sun same su in bana nan sai su kasa zuwa, more especially ma a harkar family planning. Sai dai lallai dole sai ina nan tukunna suke abin nan, sannan kuma a karban haihuwa shi ma ina samun matsala in bana nan akwai damuwa, gaskiya akwai wannan matsala.
This is the only ward they have. It's in deplorable condition. Look at the floors are cracked, the wall also cracked, the roof there is all leaking, and the windows they are all broken. Look at the beds, only few beds, and this is the only ward that is serving both male, female, and children. You can see the privacy is already compromised, and this is a facility that is taking care of about 10 communities, covering about more than 6,000 population. And because they have only 3 staff, of course they cannot run a complete 24-hour services. So people understand that if they come in the night, they will not be attended to. For that reason, most women prefer to stay and deliver at home. With all the complications, sometimes prolonged labor, sometimes with even postpartum hemorrhage and even death.
Damuwan da dai mata suke da shi shine idan suka zo aihuwa suna yawan kaman zuban jini. Dalilin da ya sa ba su cika zuwa wannan asibitin ba saboda shine ma'aikatan in sun zo da zaran an yi karfe 1:30 sukan tashi, babu wayanda kuma da su zo su karbe su kuma shikenan sai dai gobe kuma.
Dama abin da yake kawo wannan matsalolin idan aka je asibiti aka kai yara a asibiti ko ba haka ba sai dai a je a rubuta muku magani ku je kemis ku je a shago ku je ku saya, ba magani a asibitin ba. To shine dama abin da ya kawo koma bayan tunda za ka je asibiti ba za ka samu magani a wurin ba to menene sai ka wuce.
In many cases, the inability of the primary healthcare centers to deliver quality care has eroded the confidence among the people. This in turn has resulted in many of them choosing instead to go to the secondary healthcare facilities to treat common ailments.
If you look at the situation now, it's such that even minor ailments like simple malaria, like cold, like diarrheal diseases, they are being taken to secondary facilities, which under normal circumstances should be addressed at the primary care centers. And if you look at even the other indices like maternal mortality, infant mortality, which is quite high in the Northeast and Bauchi State in particular, can be addressed at that level without really going further.
In Bauchi State's Das local government area, for example, only one general hospital serves the entire populace of over 100,000 people. And many of the cases that are brought here could have been managed at a primary healthcare facility. To make matters worse, this hospital has only one resident doctor to attend to all the patients.
There are so many challenges that we're facing in this facility, which has culminated to give a lot of problems that is beyond the capacity of the staff in this facility. We actually need an increase in the total number of doctors that will deliver quality services. I alone cannot deliver such services. I consider that as indeliverable by a single doctor to attend to O&G services, pediatrics, to also attend to surgery and internal medicine services. Apart from that, we have OPD services, outpatient department services, that patients tend to come to the facility, and after being attended to, they go out of the facility. It makes the job so difficult, so tedious, because the staff actually are overworked. The inadequacy of the manpower that cannot cater for the community has actually increased the number of mortality that we have, and the morbidity also has increased. I think these are some of the negative impacts on the facility.
Just like most other states in the Northeast, Taraba's public health sector is plagued with many challenges, especially a lack of skilled manpower and non-availability of drugs for patients. The first referral hospital, Sunkani, is a classic example of a hospital saddled with huge responsibilities, but with grossly inadequate resources to carry out these responsibilities.
In the past, the government used to give us running costs to just buy some few things, but for some time now, they've not been able to sustain that. Most of the equipment we use now, they are worn out, as simple as forceps. We don't have incubators, we don't have simple oxygen cylinder to do simple resuscitation of maybe severely asphyxiated baby or preterm babies. Since we don't have these materials, the quality of care we give is nothing to write home about. Sometimes you know what to do, but because the materials are not there, you find yourself seeing people dying helplessly.
In all the primary healthcare centers in Taraba State, as at now, there is no drugs available. Let's take, for instance, a patient that comes around 2 a.m. and the patient needs some urgent medication. You know, you have to wait until in the morning when the shops open before that person can be attended to. Because if the drugs are not available, it means no help can be rendered to that patient.
The primary healthcare center, Tau, is located in a small farming and fishing community 4 hours from Taraba's capital city, Jalingo. Being the only primary healthcare center that caters for the people here and the surrounding communities, majority of the women and children come here for basic health services. However, the hospital has neither the staff nor the resources to provide proper care.
Mun muke sa domin saboda an yi shi domin ta taimaka ma jama'a mutanen Tau. Da an aje mu domin saboda mu taimake su ne, amma da an zo an kawo mu an zo aje maganin babu da me zama taimake su. Kaga zai zama na da ciwon kai. To ana kuma wannan gurin din kuma before ka samu wani staff wanda training staff ma sai kai kuka da yawa domin mutanen ma na wayansu suna kiwo ya zuwa karatu ne bile maka ce sai ka samu shi kusa. ina fi son idan mutum ya zo ya kamata a taimake shi amma with this idan babu shi kaga akwai zafi sosai a rayuwar mutum.
Like many other primary healthcare centers in Taraba State, the challenges of this health center are compounded by distance. To get to the city, one has to drive 4 hours across barely motorable roads, and one wonders what happens in the case of an emergency. To address this situation, the federal government, supported by the World Bank, is implementing a revolutionary approach to primary healthcare delivery through the Nigeria State Health Investment Project, NSHIP. NSHIP is an innovative financing mechanism for primary healthcare, which aims to finance results using the performance-based financing, a method also known as PBF. Under the PBF process, health facilities are paid based on the volume of delivery of pre-agreed health services and the achievement of approved standards of quality of care.
What gets to the people is the service that they receive. Whether we bought vaccine or we bought syringes or we bought all these things, if children are not immunized, then we have not achieved what we are saying. So we say, okay, if you immunize these children, with government of Nigeria providing the inputs for you, if you immunize these children, we will buy that service.
Previously, we will measure performance and well-being in the sector using input. How much money are we putting? How many doctors are we employed? How many nurses are there? How many buildings have we erected? But to me, they do not really tell a good story as to how well that really sector has performed. So we're looking at a different performance. We are looking at productivity of the human resources there. We are looking at patient satisfaction. We are looking at the usage of the facility, attendance, and so on. So we're using many things together. And to me, this is what makes NSHIP unique.
What NSHIP aims to do with PBF is to put the funds directly in the hands of the health facilities. Therefore, they decide how they want to use it to service delivery.
In the course of several decades in the health sector, we've had challenges with governance and accountability. We had issues with human resource availability, financial resource availability, even infrastructure was a problem. So a lot of health facilities did not have operational funds. So for instance, if there's a leaking roof, who fixes it? It takes forever if you're going to wait for the state or the federal government to fix a roof. But with the availability of funds dedicated for operational use from this project, it is now possible for the health worker to manage, in a very autonomous manner, the challenges that they face at that level without recourse to bureaucratic processes that delays the ability of the health facilities to address pressing problems.
This is not the first time PBF will be implemented in Nigeria. In 2013, in an effort to speed up progress on reducing preventable maternal and child deaths in Nigeria, NSHIP was introduced and piloted in Ondo, Nasarawa, and the northeastern state of Adamawa. The improvement in health indices in these 3 states shortly after the introduction of NSHIP was dramatic.
Recently, they just concluded the National Health Facility Survey, and what we see is that Adamawa State is coming first nationally, Ondo State second, and Nasarawa State third. So the 3 of our states that are in NSHIP are within the first 10 in the country. But let's put it in context in the case of Adamawa State. Adamawa State, as I said, the Northeast region is one of the regions in this country that are lagging behind. And for Adamawa State to have moved, and be number 1 in the country, I think this is very, very significant. This cannot just be by chance. It has to be that by something has happened, to take them from where they were before, to being the number 1 in the country.
Following the remarkable successes recorded in these 3 states, the federal government and the World Bank have now decided to scale up the program to cover the entire northeastern states of Bauchi, Gombe, Taraba, Borno, and Yobe. and the total of $154 million will be injected into their respective health sectors in the next 3 years. Most of the health officers are already excited about the program. They plan to use their funds to renovate their facilities, procure drugs, and motivate the staff to work even harder so they can earn more and do better. For many of these overworked and undermotivated staff, NSHIP is an answer to prayers.
Muna kuka ba maganin ba ma'aikata ko kuma su based on that program sun ce zaka nema magani zaka nema mutanen da zai kai aiki ko zuwan kuma kun fara ganin na san hankali na a pharmacy wanda za a yi ajiya na magunguna kun ga shine tukuna aka fara tabawa domin idan an gyara gurin idan an kawo maganin zan aje to sana abubuwan zai biyo ba sai su biyo baya.
This is the first time in the history of the country, or in particular the history of Taraba State, where a health facility will be given independence to procure, to hire and fire, and above all, based on their own business plan, do whatever they feel they should do, provided it will be translated into results for the benefit of women and children of their community. I think this is one of the most wonderful things that has ever happened to Taraba State.
Everybody has a feeling and belonging to that program. The autonomy has given them that feeling of ownership. We do it, we get the gain, we improve on our services. More people come to the clinic, more services are given, more bonuses are gotten, and there we go.
I think innovation is what we need. Innovation is what we have done. So we have to do things differently, and this is what NSHIP has done. Do things differently.
As governments, donor agencies and organizations come together to rebuild the Northeast, NSHIP aims to restore life into the health sectors of these various states through performance-based financing. The hope is that the same success that was recorded in the original pilot states will be repeated here, thereby reversing the tide and changing the health indices of Northeast Nigeria for the better.